Hello. Hi everybody, thanks so much for coming today to the Distinguished Lecture Series. I'm Lisa Shave. I'm the Medical Laboratory Technology Program Coordinator here at the college. And I had attended the New Jersey Association of Blood Bank Professional meeting that happened in May, I believe it was. And while I was there, I was really touched by one of these sessions. And so I invited Cattell here today. I'm just going to tell you a little bit about her, so I'm just going to read right from the flyer, which I'm sure you all saw. But this session is going to be about the crisis. Cattell is a part of Heroes for Moms. She's also the ambassador and co-author of Nobody Told Me About That. So she's here to teach us and talk to us about the multifaceted issues that contribute to the maternal health care crisis and what is being done to combat them. She will discuss the impact of safe blood products on maternal outcomes and the lessons learned from surviving 2 near-death events related to her first pregnancy in 2015. And before I hand it over to her, I just wanted to let you know that we are hosting our first blood drive here at the college on Wednesday, October 2nd. So as you're exiting this session, I will have a sign-up sheet if you're interested in donating blood. So thank you so much, Casey.
Thank you, Lisa, and thank you for coming and for inviting me to share my story and to share about the work that we're doing to combat the maternal health crisis in the U.S. and especially in New Jersey. Many of you may know that New Jersey is ranked in the bottom quadrant nationally, so we have a tremendous amount of work here to do in our home state. For me, raising public awareness of maternal health issues is personal. It's also ensuring communities have an adequate blood supply. I would not be standing here today if it were not for blood donors just like you. So as Lisa has shared, there's a blood drive coming up next week. Please make an appointment. Please keep your appointment. Enlist your friends, your family, your neighbors, your roommates, whoever. Bring them in because the gift of blood is really saving a lot of lives and having an impact far, far greater than you know. This. Okay, so this is our outline for today. And first and foremost, you might be sitting here wondering how maternal mortality affects you. The short answer is that there are 2 types of people in this world. There are those that are mothers, and you've got one. So it affects all of us in different ways. You likely know someone who's expecting a baby as well, and if you do, you know that there's excitement and joy over that new life in that family. Now imagine for a moment how unexpected and devastating a maternal death would be. It wouldn't just affect the baby for a lifetime. It's so much more than just a baby growing up without a mother. And certainly that is a devastating aspect of it, but it leaves a gaping hole in the lives of that child, the family, but also the community at large. It affects her partner. It affects her extended family, her friends of friends, her healthcare providers, her coworkers, her neighbors, and it affects the partner circles too, the grandparent circles, her sibling circles, and the list just goes on and on. One maternal death devastates an entire community and reverberates far beyond the people that know the mother personally. Why should you care about maternal mortality? Because it affects every single one of us. One mother lost is one too many. We will be covering many aspects of the crisis this afternoon, and it's a very complicated topic that's both heartbreaking and greatly concerning. It's said that the state of maternal and infant health care is the barometer for our nation's overall healthcare system. And if that's the case, the United States has an awful lot of room for improvement. My goal with this presentation is to give you an overview of maternal health in this country, the movement to reverse increasing rates of mortality and morbidity, and how it relates to blood banking. My greatest hope is that what I say today will move you deeply, as it has moved so many of us who have been touched by it. The maternal health crisis is a public health crisis, and we each have a role to play in reversing these trends. Inaction is not an option. The time is now, and we don't have any mothers to spare. Maternal mortality and morbidity have been in the shadows for far too long, but thanks to groundbreaking investigative reporting by ProPublica and USA Today over the last 2 years, along with maternal health care movements like the March for Moms, the curtain is finally being pulled back. While the individual circumstances leading to each death and near death may be different, many of the threads are often the same. There is a general lack of awareness surrounding the risks of common procedures like C-sections. There is a lack of education about the warning signs of perinatal complications. And many healthcare providers are dismissing patients when they do seek medical attention. I see the red flags of my own case far more clearly now, and it's through this lens of this harsh experience that I share my story with the hope of being a warning to others. If I did my best to educate myself during pregnancy and missed all of this, how many other women are missing it too? Future mothers and expecting families won't know the pitfalls in maternal health care if survivors like me are not willing to share what we have learned along the way. In early 2015, my husband and I learned we were pregnant after suffering from infertility for more than a decade. As you can imagine, I was thrilled when we conceived naturally. The same day I found out, I went to our local bookstore and bought every pregnancy book I could get my hands on. Over the next several weeks, I devoured them and was researching things constantly. I knew the changes I would experience each week, how my baby was growing, and what I should be doing to optimize a healthy pregnancy. I was determined to do everything I possibly could to keep it thriving. I felt prepared and ready for our miracle baby to make his grand entrance into the world. But despite my confidence in what I felt was due diligence to educate myself at the time, I had no idea that a crisis was lurking at my door. I had no idea that the rates of maternal mortality and morbidity were increasing in the United States, or that rates were especially poor in my home state of New Jersey. Because most mothers do well, patients and healthcare providers strongly tend to expect the best and often are not prepared for the worst. No one was talking about it back in 2015. I thought maternal mortality was a problem confined to developing countries that lack basic medical infrastructure. It never occurred to me that I should be on alert too, because it's happening here. Every conversation I had with my healthcare providers was about the health of my baby. My obstetrician went out of her way to prepare me for the possibility of a miscarriage, but to my recollection, she never once discussed my general risks of being pregnant beyond that. Maternal mortality, morbidity, and C-section risks never came up during the 15 hours of birthing classes I took with a registered nurse from labor and delivery either. And any mention of obstetric complications was brief and relegated to the back of the books I was reading, usually in the form of a list, and prefaced by a statement along the lines of, "This is incredibly rare and won't happen to you." Statistically speaking, most women will go through pregnancy and the postpartum period without any problems or any major incidents, but I can tell you from personal experience, these conditions are not rare enough when they happen to you or to someone you love. When I became a first-time mother, I also became one of the 50,000 new faces added to the maternal health crisis in the United States that year. It would be a gross understatement to say I had a challenging pregnancy and postpartum, having dodged death not once but twice within a 4-month time frame. Battling silent killers was not something I ever anticipated during the last days of my second trimester or a week following delivery. In both cases, my symptoms were subtle at first, too. And in both cases, I very nearly missed the glaring warning signs that death was imminent. It began when I noticed that scaling the stairs in our 2-story home winded me late in my 5th month of pregnancy. Shortness of breath crept in so stealthy that I dismissed it as a normal part of pregnancy. A few days later, my blissful pregnancy turned into a high-risk nightmare. At 24 weeks, I barely escaped the clutches of one of the leading causes of sudden maternal death, pulmonary embolism, or blood clots in the lungs. Because it was so unexpected, I didn't see the danger in my situation immediately or even in the early aftermath. Gasping for breath and nearly collapsing in the stairwell at work were not enough to alarm me. I was ready to go back to my desk and start a new work week because my symptoms dissipated within 20 minutes. Thankfully, there were people around me who recognized the seriousness of my situation. I was healthy, and the baby was hitting all of his milestones. What could possibly be wrong? And I easily could have cost me my life that day. After a decade of infertility, I would have done anything to safeguard my newborn son. However, I did not have the same sense of apprehension about my own health. I can't stress enough that the only reason I agreed to go to the hospital that day was because I was pregnant. I remember awkwardly laughing as the EMTs wheeled me out of my building. It was embarrassing, and all I could think about was how ridiculous I felt and the enormous cost I would incur from an 8-mile ambulance ride when I knew I could drive myself. Even though my heart rate was still near 160 beats per minute, 5 hours later, I was ready to leave the ER. After a slew of normal test results, and thankfully my doctor was thorough and persistent. He insisted something was causing my pulse to spike, and we needed to figure out what it was. I cringed to think what would have happened if I left the emergency room that day. I credit him with ensuring my son and I had a fighting chance at surviving bilateral pulmonary emboli. The scary part is that so many of the symptoms I was experiencing were a quote-unquote normal part of pregnancy. Symptoms like slowness, shortness of breath, severe leg spasms, and fatigue. All of the pregnancy books I was reading told me to expect them. But I was unknowingly blaming the pregnancy for signs that should have triggered an immediate trip to the emergency department. Since becoming a 2-time maternal near-miss survivor, I have learned that patient and physician education are imperative for more women to walk away from these type of conditions. I wasn't aware of the signs and symptoms of blood clots, nor did I know that pregnancy increases your risks up to 4-fold and then 100-fold a week following delivery. I was even reluctant to seek medical attention for clear, acute breathing difficulties. My son and I survived because of a strong network of medical professionals and an ER doctor who understood how blood clots manifest themselves in pregnant women. 4 months later, I would again be up against denial and delay. After a relatively uneventful labor and delivery, I thought all of the scary things I faced during my pregnancy were finally behind us, and we could focus our attention on being a family. Regardless of my continued blood thinner therapy, and the fact that I had an emergency C-section when labor stalled, I don't remember any of my healthcare providers telling me that I should continue to be on alert. I also don't recall hearing anything about the risks associated with a C-section and that having one dramatically increases your risk of blood clots and bleeding. I was 6 days postpartum when I started to feel different. My abdomen hurt and I decided it warranted a call to my doctor. After hearing my symptoms, the on-call physician was confident that the pain I was experiencing was a common postpartum complaint. The uterus was contracting to its original size, and breastfeeding was speeding up the process. Being a first-time mom with no experience in the postpartum period, I trusted her assessment. I had no reason not to. But around midnight, I woke my husband up and tearfully handed our son to him. I was in so much pain that I could not physically care for him anymore. That act alone should have been a much bigger red flag than it was at the time. Maybe it was stubbornness, stupidity, or the fear of being an unnecessary burden to my doctor, but I didn't call her again until the next morning. I was convinced it was my uterus contracting like she said, and I just had to get through it. Little did I know I was slowly dying on my bathroom floor with my husband and son in the next room. When I finally spoke to the on-call physician again the next morning, she said I could go to the ER, but that I could probably administer treatments myself at home more comfortably. My next 2 calls were to my mom and sister asking for help because we knew something was wrong, and when they arrived, I could tell by the look on their faces that they were shocked to see me in such bad shape. I could barely stand up, let alone walk. 2 hours later, I still wasn't feeling any relief, and I kept saying I just want to go to sleep. And that's when my mom urged me to call the doctor again. After experiencing a near miss during my pregnancy, I could not reconcile that I would be facing such a dire medical condition again so soon after. I was scared what the on-call obstetrician would tell me when I called a 3rd time in 24 hours. She didn't disappoint. She finally told me to go to the nearest emergency room just in case we're missing something. I'll never forget the sound of her voice when she said those words to me over the phone, and I remember thinking, we've lost so much time. At this point, I was in so much pain that my husband had to dress me and carry me out of our bedroom. My mom asked why he wasn't calling an ambulance, and he responded, I can get her there faster. He didn't think I had enough time to wait for an ambulance. As we neared the top of the stairs, I looked into my son's room, and there my mom sat in my nursery chair, gently rocking my newborn in her arms. I knew we needed to hurry, but I asked her to bring him to me. I was very aware this might be the last time I ever saw him again. My thoughts raced through 100 different scenarios, and I didn't want any one of them beginning without me kissing him goodbye. I was too weak to hold him, so my mom just held him up for me to kiss while I clung to my husband for support. The physical pain was excruciating, but this is the moment that broke me into a million pieces. No new mother should ever have to say goodbye to her baby like this. I'll never forget the look on my husband's face in the ER that day, while the doctors and nurses frantically worked to stabilize me in the trauma unit as my blood pressure plummeted to 37/25. He stood at the end of my stretcher, firmly holding onto my feet as though his grasp could keep me on this side of death. His expression spoke volumes about the mountain of fear and heartbreak he was feeling without uttering a single word. We have far too many memories like this. What we didn't know at the time was that I was suffering from a massive internal postpartum hemorrhage that was exacerbated by a super therapeutic INR from too much blood thinning, along with multiple bleeding sites. I ended up losing a total of 5 liters of blood and required 22 units worth of blood transfusions, packed cells, plasma, and platelets, with a hope and a prayer of surviving the emergency surgery that I needed to stop the bleeding. I later learned I had 2 secondary conditions as well: disseminated intravascular coagulation, which is a rare clotting and bleeding disorder known as death is coming, and sepsis, making my situation even more catastrophic. Thankfully, the medical professionals at the nearest hospital were ready for a complicated postpartum patient like me. They had OB trauma protocols in place already. They had been working on it for years before I ever walked through their doors. They were able to coalesce a multidisciplinary team of experts very quickly. They had access to an in-house blood bank too. Without these resources and their heroic efforts to save my life, I would not be here to raise my son. Being deathly ill after delivering a baby is a bitter contradiction. Kissing my baby goodbye just in case I didn't come home again was one of the most crushing parts of my experience. I'll never forget the surge of grief and anger I felt raging through my body after being away from him for more than a week. This isn't how motherhood was supposed to be. It was supposed to be me home caring for him, but instead, I was alone in a hospital room, with strangers helping me do very basic things like go to the bathroom and bathe. It's not something I ever considered to be a part of my son's birth when I was planning for it. When one of the best moments of your life becomes one of your worst, it's a paradox few can empathize with. And for a long time, I blamed myself for coming a razor's edge away from leaving my son motherless. Even with the on-call doctor's confidence that my symptoms were normal, I felt I should have trusted my body more and enough to act without her direction. I also had a hard time coming to terms with how a senior obstetrician did not take the time to examine me after that first call. I was a high-risk postpartum patient on blood thinners with a C-section and a prenatal pulmonary embolism near miss under my belt. If ever there was somebody to err on the side of caution with, I was her. If denial and delay affected me like this, what is the response to women without such a complicated history? To the women without resources like insurance and access to care? Those thoughts haunt me to this day. In hindsight, I recognize that the on-call doctor and I both significantly misjudged the situation, and we share in that denial and delay. It's one of those things I will always wonder about. Had I received medical treatment at the onset of my symptoms, would my hemorrhage have been as severe? Could the trauma, grief, and long-lasting physical effects like memory loss have been avoided? From the time I was discharged from the critical care unit after my pulmonary embolism episode to the year following my hemorrhage, I felt like I was expected to bounce back as if nothing traumatic had happened. Many people incorrectly believe a near miss is an acute emergency and then it's over. However, a near-death event is often accompanied by long-term health problems and is usually a catalyst to a lifelong shift. Survivors have seen the dark side of childbirth up close, and it's affected us so deeply that we can't stay silent and watch it happen to more women. As the mothers who made it home, we feel a great debt to the moms who didn't, and to the babies who grow up without them, and that's why I'm here today. Like many new survivors, I was stunned when I learned the magnitude of the crisis. Postpartum hemorrhage, preeclampsia, HELLP syndrome, pulmonary embolism, placenta accreta, amniotic fluid embolism, postpartum cardiomyopathy, infection and uterine rupture, just a handful of the deadly conditions that are killing new mothers each day. Thank you. Despite spending over $3 trillion on healthcare, the U.S. ranks below 49 other countries for maternal mortality and is the most dangerous place to give birth of all industrialized nations, according to Merck for Mothers. An average of 2 mothers lose their lives each day in the United States, and more than 150 mothers, like me, come extremely close to dying. These lost mothers leave gaping holes in new families, and those who survive often suffer from complications like post-traumatic stress disorder, sky-high postpartum anxiety, and postpartum depression, which, as you can imagine, compound an already difficult physical recovery. Maternal death and near death deeply impact families during what should be a joyous time celebrating the birth of a child. Sadly, many people simply aren't aware of the dangerous complications and the symptoms that should trigger an immediate trip to the emergency room. According to Dr. Neil Shah, a Harvard Medical School obstetrician, an American mom today is 50% more likely to die in childbirth than her own mother was. A report released by the Centers for Disease Control and Prevention earlier this month supports that assertion, concluding that Black women, along with Native Americans and Alaska Natives, are 3 to 4 times more likely to die before, during, or after having a child, and more than 50% of these deaths are preventable. It is believed that racism is the greatest risk factor for these deaths, partly because of implicit and explicit systemic racial bias towards women in accessing care, and because healthcare providers are not recognizing risk factors such as high blood pressure, which could lead to preeclampsia, for example. As in my case with increased estrogen during pregnancy that led to the blood clots, pregnancy can reveal previously unknown problems or even contribute to new problems. Ultimately, pregnancy is a stress test on the body that provides a window into future health. This is where the U.S. is compared to other nations. Mind-blowing, isn't it? So what is causing the uptick in maternal deaths when maternal mortality ratios are declining in other countries? Many maternal health experts believe maternal mortality in the U.S. is a multifaceted problem, and from a numbers standpoint, mortality is the tip of the iceberg because severe maternal morbidity outpaces mortality by nearly 70 to 1. While bleeding and infections used to cause most pregnancy-related deaths in the U.S. and still do worldwide, heart-related problems are now emerging as the lethal front-runner. Additionally, possible factors for raising ratios of mortality and morbidity include the high C-section rates we've been seeing in the U.S., which account for 1 out of every 3 births now. Life-threatening complications like placenta accreta, increta, and percreta, which occur when the placenta invades the uterine wall and surrounding organs, resulting in severe blood loss after delivery, have seen staggering increases, as high as 300%, and are proportional to the rising national C-section rates. Other factors that contribute to the surge of near deaths and deaths include chronic illness, and soaring rates of obesity, which raises the risk of heart disease, diabetes, and other complications. Advanced maternal age. First-time mothers are older than previous generations. Lack of insurance. It's estimated that up to 40% of women do not return to their 12-week postpartum visit because of payment issues. Access to care. There are maternal health care deserts in rural areas, with many expecting families traveling more than an hour to receive basic prenatal and postpartum care. Many labor and delivery units and practices are closing due to skyrocketing healthcare and liability insurance costs, many of those even in Philadelphia, as close as Philadelphia. Less contact with patients in the postpartum period. Obstetricians are overworked and burnt out. Adding more visits only will exacerbate that burnout. There is less integration of midwifery model of care and low intervention births. North Carolina is one of 6 states that forbids certified professional midwives from delivering babies and providing prenatal exams and other maternal care. It's believed embracing midwifery nationally will help alleviate the maternal health care deserts and address obstetrician burnout. However, many organizations are opposed to this for a variety of reasons. Denial and delay were highlights in the ProPublica Lost Mother series as 2 of the biggest factors leading to preventable maternal mortality. In short, denying the existence of a problem delays the treatment, which dramatically affects the outcome. Tragically, there are cases where people do not have a timely and accurate diagnosis, And even when they do seek medical treatment, they are often sent home despite obvious warning signs. There's also large gaps in perinatal education for expecting families. Few healthcare providers and birthing classes are tackling the difficult topic of maternal mortality and morbidity because many believe it will frighten families. As you can imagine, I am in the camp where I believe education is not a scare tactic. It will absolutely save lives. All of these factors lead us to the perfect storms of circumstances that have made the United States the most dangerous industrialized country to give birth in. And in many of the mortality cases, 3 to 4 of these factors that I just listed were identified. New Jersey. Despite having some of the best hospitals in the country, New Jersey is in the bottom quadrant nationally. We have a tremendous amount of work to do to ensure more mothers return home to their families. Progress is being made on many fronts. For example, New Jersey First Lady Tammy Murphy is spearheading a campaign called Nurture New Jersey, which aims to combat our high maternal mortality rate by tackling structural racism in healthcare. Rutgers Robert Wood Johnson Medical School, along with Robert Wood Johnson University Hospital and the Tara Hansen Foundation, have created 2 initiatives as well. Maternal Health Awareness Day, which occurs every January 23rd, and the Stop, Look, and Listen campaign. Both strive to raise public awareness and urge healthcare providers to create meaningful policies and protocols to overcome the bias involved in denial and delay. As with all change, progress is slow, but this is a moment of reckoning in our state. Here's a look at the leading causes of mortality. As you can see, hemorrhage remains one of the leading causes in the United States and worldwide. Denial and delay continue to be contributing factors, especially for cases of internal or secondary postpartum hemorrhage, which can occur days or weeks after delivery. Recently, maternal suicide resulting from poorly treated postpartum mood and anxiety disorders, or PMADS, has emerged as a rising cause of mortality. Appropriate treatment for maternal mental health conditions is lacking almost everywhere in this country. There are 3, count them, 3 perinatal mental health treatment centers in the United States. In addition to these groundbreaking treatment centers, organizations like the Bloom Foundation, which is located at Monmouth Medical Center in Long Branch, New Jersey, and the Postpartum Support International are working hard to combat the stigma of PMADS and train existing healthcare providers to treat them appropriately and compassionately with the mother-child bond in focus. In many of these cases, if a woman does let her provider know that she is having suicidal ideations or intrusive thoughts, many of these moms are removed from their children and institutionalized. And that is the worst possible thing you could ever do to a new mom. Some publications will say up to 70% of hemorrhage deaths are preventable. Others, like USA Today, report that 90% of hemorrhage deaths could have been avoided. One of the issues with statistics like this is that no one really knows the full extent of the problem due to a lack of data collection and standards for how the data is gathered. Shockingly, maternal mortality review committees are not functioning in all 50 states yet. And of the states that do have them, the data is not always used to implement corrective actions in meaningful ways. As you'll see later, legislation is being introduced to address this problem on a federal and state level. Before my own hemorrhage, I had little understanding of the conditions that would cause severe bleeding during childbirth. I didn't know moms needed blood transfusion at all. I had never heard of things like accreta, uterine inversion, abruption, HELP syndrome, or even uterine atony. All of these root cause conditions of hemorrhage are related to one or more of what is called the 4 T's. The first is tone, or uterine atony, where the uterus doesn't contract enough to compress the uterine blood vessels adequately, and this accounts for about 70% of postpartum hemorrhages worldwide. The second is trauma, such as a laceration or tear during delivery. The third is tissue, like retained placenta after delivery. And the fourth is thrombin, also known as an underlying bleeding disorder. New Jersey is embedded in the front lines when it comes to raising awareness of maternal health crisis in the U.S. With assistance from the Robert Wood Johnson Medical School and Robert Wood Johnson University Hospital, the Tara Hansen Foundation developed the Stop, Look, Listen campaign in 2013. The goal is to increase public and professional awareness of pregnancy-related deaths, empower women to report pregnancy-related medical issues, and increase awareness and responsiveness among healthcare practitioners. The campaign seeks to educate all healthcare providers, not just OBGYNs, both labor and delivery nurses and midwives, but it also seeks to educate family members and emergency room physicians who may be the first to recognize something is wrong with a woman who has just given birth. The campaign prompted New Jersey law establishing January 23rd of every year as Maternal Health Awareness Day. It was the first day of its kind in the nation. Both Pennsylvania and Delaware have followed suit in 2019, and many other states are expected to join the efforts as media attention and public pressure increase. In 2018, the American College of Obstetrics and Gynecologists, or ACOG, rolled out their Every Mom, Every Time initiative to help eliminate preventable maternal deaths, urging clinicians to become a part of the solution and empowering families to speak up. There are dozens of other maternal health organizations and initiatives, some like the Black Mamas Matter Alliance, the March for Moms, and Mama's Voices. They are doing amazing work to raise awareness, advocate for change with lawmakers, and coalesce stakeholders from various groups to make changes in healthcare that will save mothers' lives. Am I ahead of myself here? Yes, I am a little ahead of myself. The Preventing Maternal Death Act of 2018 was signed into law by President Trump mere hours before the government shut down in December of 2018. This was a huge win for the maternal health camp, as the bill establishes a program under which the Department of Health and Human Services can make grants to states to review maternal deaths via maternal mortality review committees. In addition to the two new bills, the Mamas Act and Mamas Act were introduced earlier this year that will begin to tackle factors involved in the crisis. You can see the first is listed as S116, Modernizing Obstetric Medicine Standards of 2019. This was introduced by Senator Kirsten Gillibrand of New York and will address rising maternal mortality rates, especially for women of color, racial disparities in maternity care access and provision, the need for data collection regarding maternal morbidity and mortality, and an allocation of resources to states to collect the data, educate health professionals on racial disparities, and address maternal morbidity and mortality. The second is H.R. 5977, Mamas Act, introduced by Representative Robin Kelly, and it will address expansion care access to the full postpartum period of 1 year for all mothers.